Yes, good afternoon. We have Dr. Grace Soka and Dr. Solomon. Yes, and you could please go ahead and share your slides. Yes, I'm glad the presenters have joined the meeting.
Okay, good afternoon all. Sorry, we are a bit late, but we are about to start. We had something happen that the radiologist, Dr. Eric, has an emergency procedure, so he cannot make it. So Irene has asked Dr. Mbabazi to help us go through the presentation. So welcome today's tumor body presentation. So I'm going to chair instead of Professor Sayoki Mfinanga. So the presenters will be Dr. David Solomon and Dr. Margaret Mbabazi, whereby Dr. Margaret Mbabazi will present the radiological findings of the patient. Thank you. So David, you're welcome.
Okay, thank you, Dr. Grace. Thank you, Dr. Irene, for the introduction. We'll start with the clinical part of presentation as well, as the selected person will help us with the radiological part. Hopefully, you all can hear me well. Okay. Quiet means yes. Okay. So, presentation, it's a case of one of our participants, a 60-year-old male living in Dar es Salaam, married, and living with his family, who was presented with a cough for more than 3 weeks with a blood-stained sputum and chest pain, which was associated with tiredness and unexplained weight loss. All the symptoms were on and off for 1 year prior to consultation here at MNH, and also they were gradually progressing in severity. He has some family history of he has been working in textile industry for more than 20 years, using charcoal as a means of energy for cooking, with a positive family history of cancer, positive history of COVID-19 illness, where he was not vaccinated, and also he has a positive history of using alcohol and smoking 1 pack a year, and also on the cause of illness, he has been treated for pneumonia without improvement at a nearby hospital, and also referred to Muhimbili in order for further investigations and management. Here are our lab investigation results, saying with HIV status negative and WBC normal range, within a normal range, as well as platelet within a normal range, prothrombin time 11.2, INR 0.97, and PTT, which were a little bit high above the reference range. On part of radiological, I will welcome the Dr. Mbabazi to help us I hope you have the slides.
Unfortunately, I don't have them, so I don't know how to present.
Or maybe you can help us to describe it here, or if it is feasible and possible. You're welcome. Thank you.
Maybe you can scroll through the images.
These are videos.
Can I have access?
I think Dr. Grace, I've shared it with you. Or Dr. Grace, you sent the slide to Dr. Hans.
Yeah.
I can't access them. You didn't give me permission to access them. Access has been denied. Yeah.
Okay.
I think you scroll through. We can just discuss them as you go along. It would have been good if you had given me these images before, because now I haven't seen them. So
I hope
bit
now
difficult.
you can access them. Yeah. We understand.
Okay, Dr. Mbabazi, while we are sorting out the issue of the slides, in case of if anybody has any questions pertaining the chief complaint and a bit of the history of the patient, you can just raise up your hand or shout so as we can go on with the presentation. Thank you.
Now anyone with a link can access the images, including Dr. Mbabazi.
I can ask some questions.
Yes.
Thank you for the presentation. I just wanted to know the patient had been in the hospital for 1 year. Which diagnosis had been given to the patient over that 1 year?
Okay, David, did you hear the question?
Yes. He's a confirmed lung cancer with pathological diagnosis of non-small scale carcinoma, adenocarcinoma.
Sorry, maybe I can clarify more. The prof is asking that the patient has been in the hospital for almost 1 year before being confirmed having a lung cancer. What was the diagnosis? What were they treating this patient for?
They were treating for pneumonia. It was on and off cough, and he was on antibiotics prior. So at the moment of consultation, the only diagnosis that he was given, they were treating it was pneumonia without improvement. And it was at a nearby hospital.
Yes, Prof, are you satisfied with the answer?
Yes, definitely, I'm satisfied. But I'm just wondering, this pneumonia for 1 year, did they attempt TB treatment?
No, I didn't go for TB.
Okay. Thank you.
Okay, thank you. Anybody else with any question? before we go to the radiological investigations? Okay, silence means we are all okay. So can Dr. Mbabazi, can we go on with the radiological findings?
I'm trying to switch to a laptop so that I can help if we can all scroll through. So I think you can discuss the management. I'll do the radiology last.
Oh, okay. David, may you go to the management while Dr. Mbabazi is organizing the radiological findings?
I think the key message was to link from the presentation with the radiological findings and the management. Yeah. So after consultation at Muhimbili National Hospital, biopsy was taken, and it came out to be non-small scale carcinoma, adenocarcinoma. Hopefully we can have the staging from Dr. Mbabazi. And the patient was given he has completed chemotherapy, and his progress is he has been continuing well compared to at the moment of presentation or at the first time we met him. And currently he's on pregabalin because of he keep on complaining on numbness on the lower limb, of which it has been presumed as one of the side effects of chemotherapy. And also, so as I said earlier, the patient is now continually, we have a follow-up CT scan as well we could appreciate the significant changes prior and after. And other part of the presentation is about the distinct changes prior and after initiation of treatment. We can see he had a number of symptoms, like 6 symptoms, and now none of them are present apart from numbness, which is already on pregabalin. So I think Dr. Mbabazi can chip in because that's much from my side.
Do you know the chemotherapy was given?
The chemotherapy? It was carboplatin and docetaxel.
Okay.
Okay.
Okay, I would request that you allow me to share to access the images by allowing me to scroll.
The link Dr. Grace have shared with you now, I believe we can access it, or you can share with us through Zoom call while you have total control of the images.
Okay, somebody else is screen sharing for me to, yes. Okay, sorry, I've been ambushed, so I wasn't really prepared. But as we look through these images, we have the contrasted chest CT scan of this patient in both the mediastinal and the lung window. I don't know whether I can, okay. So this is the mediastinal window. And I'm going to play the video and pause it when we see something that is interesting. It's a bit fast, so let's go slowly. So this is the level of the aortic arch. I already see something like a lymph node in the in station 4L, that is the lower paratracheal station. Okay. And at this level, we can already see a mass or a mass-like consolidation in the left lower lobe. And as we go through, we see a lobulated soft tissue mass in the left lower lobe. There's an eccentric calcification on it. I don't think I'll be able to measure its size, but we see a solitary lobulated soft tissue density mass in the left lower lobe. Okay. So that is what the video is a bit too fast, but that is what I'm seeing. I think I've seen something also in the axilla. There appears to be a very big lymph node in the left axilla. And in the lung window, let's see what we can see. So in the lung window, you're really looking for any other lung parenchymal changes like fibrosis, like emphysema, but also it is the window in which we are supposed to measure the mass and also look at its relationship with the airways. So we still see a mass in the left lower lobe. It is solitary. There is not much associated with it. There are no lung-to-lung nodules or surrounding nodules around the mass. So we see a huge mass in the left lower lobe with, I managed to see only one left lower paratracheal lymph node. Then when we look at the images, I think this is after treatment. I cannot conclusively say much, but it appears to have enlarged. No, actually, this is the time they did a biopsy, because I can see the biopsy needle at some point. Yeah, so this is the biopsy needle. So this was the time at which they biopsied the mass, and it appeared to have been bigger than when the patient presented. So I suspect there could have been a delay between diagnosis and biopsy. I'm not sure what the presenters had prepared for these additional images. Maybe Grace, you can take it over from here, but clearly the mass is bigger at the time of biopsy than at the time of presentation. Thank you.
Okay, thank you, Dr. Mbabazi, for the good presentation. Yeah. So I welcome, if anybody has any questions for Dr. Margaret, any
Dr. Margaret,
clarifications.
can you help us with the last CT scan on follow-up?
After treatment.
Yeah, after treatment on July. Thank you.
Hello. Dr. Margaret, were you able to access the post-treatment images? So maybe I welcome any questions, any comments before Dr. Margaret. If anybody has any questions concerning the images which Dr. Margaret has presented.
No question. Of course, it would have been good.
Sorry, my
for-
volume button went off, but I can now present it.
Okay, you have the follow-up one, eh?
Yes.
So these are the follow-up CT scans for the
Thank you.
patient. We can look through them together. So we can see an evident reduction in the size of the tumor, which was previously noted in the left lower lobe. And let's look at the lung window. The lung window usually gives us a more precise assessment of the extent of the tumor. When we look at the mediastinal window, we will miss the ground glass component of the tumor, but in the lung window, we're able to see it. So it's best to measure the tumors in the lung window. So in the left lower lobe, we just see this residual speculated mass, which is markedly reduced in size. So this is a remarkable radiological improvement. Back to you, Grace.
Okay, thank you very much, Dr. Margaret, for the presentation. So I welcome anybody who has any questions. As you can see, before and after treatment, there is reduce of the tumor, as Dr. Margaret said. Yes? Yes?
I don't know, maybe Prof, you can say something because Grace is not saying.
Yeah, I can hear her. Grace, can you hear us?
Yes, I can hear you. Can you hear me?
Yes.
Hello? Yes, Dr. Margaret, can you hear me?
Did you hear anything I said?
Yes, we did.
Okay, sorry. Yeah, so I was saying that there was a remarkable radiological improvement from a huge tumor to just a focal scar that is now left. And then I had told you to comment. I don't know whether you heard me on that.
I heard you.
Okay.
My question to Margaret, if she's hearing us, is...
I'm hearing you, yes.
Yeah, you know, with the tumors, if we didn't know properly the staging of this tumor, the resolution of the single parenchymal mass is good, but we may want to know whether they were metastases. You had seen a lymph node. I don't know whether it has gone away.
Let's try and see it again. Okay, so the lymph node seems to still be there, but it is, I didn't have the measurements, but it is still there, the lower paratracheal lymph node, but I don't see any other new lymph nodes. The fact that it's a video, I cannot window to look for any bone involvement, but the lymph node is still there, but the tumor has reduced in size.
Okay.
Okay, so Grace, back to you.
Okay, thank you very much, Dr. Margaret. So I welcome if there's any question, any comment. Hello, anybody has any question? Any comments?
I wanted to ask a question.
Yes, go ahead.
I don't know if I missed this, but did they do an X-ray before, and did it show the mass? Like, could the diagnosis have been figured out, or an idea have been created on the X-ray?
Okay, David, can you respond to that question? Were there X-ray images?
On the presentation of the patient, they took a CT scan. There are no chest X-ray taken. None of I have recorded so far. Yeah.
Yeah, but given the size of the mass, I'm pretty sure an X-ray would have picked it. So an X-ray would have helped to begin with, and probably demonstrate the non-resolution of the pneumonia, which was being treated, and it would have given a hint that this is most likely not a pneumonia. So an X-ray could have worked in this patient. It was a huge tumor.
Okay, thank you, Dr. Margaret, for the clarifications. So are any more questions or comments?
Grace, seems there are no other comments, none from me.
Okay, thank you, Prof.
Maybe
So,
yeah, so maybe we can I think most of the points and the messages we could hear them from our specialists who had an emergency. And I hope next time we could try to plan this well and do better on delivering it, even if in case of any emergency, so that we don't miss the part of the presentations as it happens for this meeting. So by saying so, I would like to thank you, everyone. And back to you, Grace.
Okay, David. Thank you. Thank you, everyone, especially Dr. Margaret, who made this happen because we had lost hope, but you helped us out. And also, I welcome Prof to close our today's meeting. Prof, welcome. Prof Bruce.
Yeah, thank you. Although some people did not come to the meeting, it is still a very important meeting to discuss this case.
Yes.
And of course, you can already see probably not many of these cases are being discussed. So thank you, Solomon, for presenting the case. What we've learned is that someone had cancer for 1 year. Symptoms and the diagnosis was not attempted. But we are happy that when the patient presented, at least has got some remission. Since this patient is still in the study, I would recommend that the patient is evaluated for any distant metastasis as part of their management. Thank you very much, everyone, for joining the meeting.
Okay, thank you very much. So this marks the end of our meeting. Thank you all for presenting and joining the meeting. Thank you very much.
Thank
Bye.
you. Bye.